everyone. Today we're going to talk about the Introduction to Theories of Behavioral Disorders. We're going to talk about Chapter 1 in our textbook, and then we're going to go through some of the supplemental research that you have. Our goals for today, we're going to summarize key points from required text. We're going to identify DSM-5 criteria for oppositional defiant disorder. We're going to identify DSM-5 criteria for conduct disorder. We're going to compare DSM-5 criteria for ODD and CD to the federal eligibility criteria for special education under the emotional impairment category. We're going to review current research related to definition, status of emotional behavioral disorders. And we're also going to review key structures of the brain associated with executive function, design making, and emotional regulation. Introduction: Connecting Brain Development, Disruptive Behavior, and Children. So this chapter was pretty light in reading, which is why you had a couple of supplemental research articles that went with it. Chapter 1 didn't provide a whole lot of in-depth information about emotional impairments, but it did give a brief overview about where the rest of the text is going to be going. So let's just talk about some of the clarifying points when we're reading the text. So when they talk about disruptive behavior disorders in the text, they're talking specifically about attention deficit hyperactivity disorder, ADHD, oppositional defiant disorder, ODD, and conduct disorder, CD. For our purposes, we're going to focus mainly on ODD and CD simply because EI encompasses those two, whereas ADHD is usually met under the OHI category for eligibility. The characteristics of disruptive behaviors mostly include aggression towards others and noncompliance, and those are two of the key features in both ODD and conduct disorder. When we're talking about diagnosis, and the book talks about diagnosis, they're talking about the subjective criteria from the DSM. They make a very distinct point to mention that even though there's been some research and some advancements in that research regarding brain scans and emotional behavioral disorders, there's nothing definitive that they can find from those brain scans that point to somebody having an emotional or behavioral disorder. Brain development is something that we're going to talk about, and we're going to review structures of the brain a little bit more because this is talking about theory and it talks a lot about genetics and it talks a lot about biology. It is going to be important to know what structures of the brain are responsible for certain functions in our body. So some of the things that they talk about is that motor and cognitive skills become more advanced as myelination is complete and synaptic pruning is complete. So when they're talking about myelination, the neurons in our brains are coated in a fatty substance called myelin. And if you think about our neurons, think of it as an electrical wire. And just like an electrical wire, they're wrapped in rubber to help insulate. So when we're born, we don't have myelin that covers the axons of our neuron. And that's why babies can't walk and they're not very coordinated, because those signals from the brain down the spinal cord to the rest of the body aren't very efficient, because they don't have anything to keep them in. They don't have that rubber coating yet. So as we get older, that myelination develops, and you can see that as children develop. So as they get a little bit older, they start to crawl, then they start to walk, then they're not fumbling around anymore. Their myelination is complete. As babies, we have many more synaptic connections in our neurons than adults do. But as we get older, especially in the teenage years, some of these synaptic connections get pruned or they get cut because they're no longer needed. So once we have synaptic pruning and the myelination, motor skills and cognitive skills become a little bit more efficient and a little bit more higher level. However, even though that happens, our brain is not fully developed until 25 years old. So even though 95% of our brain is done developing by the time we're age 6, the important part, the frontal lobe, isn't developed until we're 25. And the frontal lobe is your executive functioning center. So it is what makes you you. It's responsible for planning, decision making, good judgment, poor judgment. And that's why when people say teenagers are stupid, not as in they're unintelligent, but they just make bad choices, that's why. The part in their brain that's responsible for making those good choices, for having that filter, for having that, ooh, let me wait 2 seconds before I actually say what I'm thinking, it's not developed in teenagers yet. And some of the brain structures that are specifically linked to disruptive behaviors include the right anterior cingulate cortex, the anterior cingulate cortex, and the amygdala. And research has shown that these brain structures all have a lower volume, and it's correlated with people who have aggressive behaviors. So remember though, when we talk about correlation, correlation doesn't mean causation. There's also an enzyme called monoamine oxidase A polymorphism, and people who express that low, typical to other, relative to other people, also tend to have aggressive behaviors. Okay, so let's talk definitions. So this is the DSM-5 criteria for oppositional defiant order. And it's a pattern of angry or irritable mood, argumentative, defiant behavior, or vindictiveness that lasts 6 months with at least 5 of these symptoms. So you have to be angry or irritable, which includes often losing your temper, you're easily annoyed or you're touchy, you're angry or you're resentful. You have argumentative, defiant behaviors. So you argue with authority figures, you actively defy or refuse to comply with requests and rules, you deliberately annoy others, and you blame others for your mistakes. And vindictiveness. So they've been spiteful or vindictive at least twice within the last 6 months. And there's mild, moderate, and severe. So mild cases occur when you have these symptoms in one setting. Moderate appears when you have it in 2 settings, and severe appears when you have it in 3 or more settings. So most of the oppositional defiant disorder criteria is going to talk about the home setting and the school setting. As with most DSM criteria in general, it has to have some type of dysfunction in your life. So these may occur on a moderate or mild level in school or at home, but it's once it starts to impair the student or the child's ability to function that it becomes an issue. So some of the other important factors about ODD, the prevalence is 3.3%. And some of the other things that go along with this disorder is children do not see anything wrong with their behavior. So anything that they do, they feel is justified. They don't view themselves as angry or defiant because they think that their behavior is justified. It's just in response to something else. Sorry, I had a tickle in my throat. Often ODD occurs when childcare has been disruptive. So if you have somebody who bounces from house to house, or you have somebody who bounces throughout the foster care system, or it's a result of harsh, inconsistent, and neglectful child rearing. The developmental course, it often starts in preschool, and ODD does precede conduct disorder, especially if there's an early onset age. Defiant, argumentative, and vindictiveness is associated with conduct disorder. Angry, irritable mood is associated with emotional disorders, so things like depression or anxiety. If it continues into adulthood, there's an increased risk for antisocial behavior, impulse control problems, substance abuse, anxiety, depression. So ODD is exactly what it sounds like, and that's how it presents in the school setting. Is somebody who is just oppositional and defiant. So you ask them to do something and they just flat out refuse. They're often angry. They often look angry. I have a student right now who, anytime I say anything to him, it could be a directive, pick up your pencil and start working. It could be good morning. It could be a general class-wide directive. He has some comment that he makes under his breath that is negative and angry and irritable. And every time I give him a directive, he just flat out refuses to do it. These students can be very challenging when they're in a classroom behavior, and it's really difficult not to get into a power struggle with them. So I often tell teachers in the beginning of the semester when I give them my report on the student that we just have a general 3-step rule. So the first is we give them a verbal direction. And that's like the whole class direction. And if they don't do what they're supposed to, then you give them a quiet 1-to-1 directive. And then if they don't do that, then you give them a verbal prompt. So like walking up to their desk and either picking up their pencil and handing it to them, or tapping the desk, or maybe pointing to the number that they should be working on. And then after that, as long as they're not being disruptive, I tell my teachers to leave them alone. And you often get caught into the dilemma of, do I push them to do the work, or do I just let them be? And oftentimes if you push them to do the work, it results in some type of confrontation that leads to them getting removed to either in-school suspension or out-of-school suspension. So at least as long as they're not being disruptive, they're still absorbing the information because they are in class. Conduct disorder is a little bit different. So conduct disorder is a more severe form, if you want to think of it that way. It's a repetitive and persistent pattern of behavior that violates the rights of others and or social norms with 3 criteria. And this one's a little bit longer, so it's going to take a couple of slides. Aggression to people or animals. Bullies, intimidates, threatens, initiates physical fights, has used a weapon that has caused serious harm to others, physically cruel to people, physically cruel to animals, has stolen while confronting a victim, has forced someone into sexual activity. Destruction of property, has deliberately engaged in fire setting with intention of causing serious damage, has deliberately destroyed others' property. Deceitfulness or theft, has broken into someone's house, car, or building. Often lies to obtain goods or favors or to avoid obligations, has stolen items of non-trivial value without confronting a victim. Serious violations of rules, often stays out at night despite parental prohibitions beginning before age 13. Has run away from home overnight at least twice or once without returning for a lengthy period, is often truant from school beginning before age 13. So conduct disorder, and it really kind of depends on what district you're in, is typically seen as maladjustment, which is excluded from special education eligibility. And this is an unfortunate turn of events because those students with conduct disorder are often the ones who are most desperately in need of services. Yet, depending on the district and how they evaluate, especially if they have an outside diagnosis of conduct disorder, they may not receive services. There's a couple of subsets of conduct disorder. The first is childhood onset, and this is before age 10. If it's childhood onset, they're typically males. They display physical aggression, they have disturbed peer relationships, and they meet the full criteria prior to puberty. They're more likely to have persistent conduct disorders as adults. Adolescent onset occurs after age 10. They're less likely to be physically aggressive, they have more normal peer relationships, and they're less likely to have conduct disorders into adulthood. The onset occurs most likely between middle childhood and middle adolescence. It's rare that it occurs after the age of 16. Early onset predicts worse outcomes. It's associated with adulthood issues such as impulse control disorders, mood disorders, anxiety, post-traumatic stress disorder, psychotic disorders, somatic symptoms, and substance abuse. There's also some specifiers when we come to conduct disorder. One is that they may show lack of remorse or guilt, or they're callous or lack of empathy. They're unconcerned about their performance. They're shallow or they have deficient affects, so they show no emotion. They're fearless. They're thrill-seeking, and they're immune to punishment. So it doesn't matter what you do, they don't care. No punishment is actually going to affect or change their behavior. They perceive others as threatening and hostile. They have negative emotionality. They have poor self-control, so they can't control what they're doing. They have low frustration tolerance. So when something is difficult for them, they just can't deal with that. They're irritable, they have temper outbursts, they're often suspicious of others. There's substance abuse, and that occurs primarily in females. People who have conduct disorder typically have suicidal ideation, and they have attempts and completions at a higher rate than the typical population. The prevalence of conduct disorder is 4%. So let's compare conduct disorder and ODD to the IDEA definition of emotional disturbance. So emotional disturbance means a condition exhibiting one or more of the following characteristics over a long period of time to a marked degree that adversely affects educational performance. So we're going to pick apart that definition a little bit later. There's an inability to learn that cannot be explained by intellectual, sensory, or health factors. There's an inability to build or maintain satisfactory interpersonal relationships. There's inappropriate types of behaviors or feelings under normal circumstances. There's a general pervasive mood of unhappiness or depression. There's a tendency to develop physical symptoms or fears associated with personal or school problems. Emotional disturbance does include schizophrenia, but it does not apply to those who are socially maladjusted. So you'll see this when you have your MET forms for students with EI. It kind of lists those criteria eligibility, those 5, and you're going to check the ones that the students have. More specifically, let's look at the Michigan rule. Emotional impairment, so notice there's a difference. We've now had 3 different types of labels for it. So the book calls it disruptive behavior. The federal law calls it emotional disturbance. Michigan calls it emotional impairment. Emotional impairment shall be determined through manifestation of behavioral problems, primarily in the affective domain, over an extended period of time, which adversely affects the student's education to the extent that the student cannot profit from learning experiences without special education support. There's an inability to build or maintain satisfactorily interpersonal relationships. There's inappropriate types of behavior or feelings under normal circumstances, a general pervasive mood of unhappiness or depression, a tendency to develop physical symptoms or fears associated with school or personal problems. It includes schizophrenia, but it does not include persons who are socially maladjusted. So you'll see each of these manifest in different ways. So the inability to build or maintain satisfactorily interpersonal relationships. I had a student who was like this. No matter what you did, you just couldn't connect with him. He didn't really have any type of connections to any of the staff or any of the students in the building. And he just really didn't care about connecting with anybody. I went on medical leave, and I told him one week that I was going on medical leave to give my caseload a little bit of time to adjust to the fact that I wasn't going to be there for a couple months. And the next week, when I checked in with him to see if he needed anything before I left, he looks at me, he goes, "You're still alive. I thought you'd be dead by now." The teachers who were around when he said that were so upset. But it's just a student who has an emotional impairment. That's typically the way that they act. And you have to learn not to take it personally. Inappropriate types of behavior or feelings under normal circumstances. So this might be somebody who cries hysterically and hides underneath a desk anytime there's an academic demand that they might think is too difficult for them. General pervasive mood of unhappiness or depression. So this might be a student who has an outside diagnosis of major depressive disorder or some type of anxiety disorder. And this often goes with the tendency to develop physical symptoms or fears associated with school or personal problems. So oftentimes there are outside diagnoses of school phobia, and there's nothing in the federal or the state legislation that makes that eligible for special education services, but many districts often do put that under the emotional impairment because there is an outside diagnosis of depression, and that goes along with that pervasive mood of unhappiness or the tendency to develop those physical symptoms or fears. Let's look at some of the related research. So the first article, A Historical Perspective of the Field of Emotional Behavioral Disorders, a review of the literature. So just a quick overview of the history of the field of emotional behavioral disorders. So in the mid-19th century, there were schools for feeble-minded to provide humane treatment and skills to function in the community. A lot of these terms are very outdated and they're obviously a little bit offensive, but these are the terms that were used back then. In the late 19th century, many of these feeble-minded students were deemed uneducable and they were placed in separate schools. So they were kind of placed out of the view of all of society and kind of forgotten about. Horn in 1910 termed students who were incorrigible and truant. In the mid-20th century, compulsory education laws were instituted, but they did exclude those with severe disabilities. Those who did have severe disabilities were placed either in residential treatment centers or asylums. The 600 schools were made in 1946, and they were schools in New York City that were non-institutionalized settings for students who were emotionally disturbed. They provided therapeutic environments to get children ready to re-enter public schools. And they had a whole host of different types. So they did have residential, they did have asylum or mental health hospital, similar type schools. They had some that were almost like public schools, all with the aim of getting these students ready to re-enter into the public school system. In the 1960s, emotional behavioral disorders were added as a disability category, and funds were allocated for community mental health centers. So community mental health centers and those wraparound services and that interagency collaboration is really key for students with emotional behavioral disorders. But as we know, anytime funding gets cut, community mental health is typically the first one that gets cut. In 1975, we had the Education of All Handicapped Children Act. And in that act, it defined EBD as serious emotional disturbance. It did provide students with emotional behavioral disorders as free and appropriate public education, what we call FAPE, that they should be educated in the least restrictive environment. The definition for emotional impairments that was used in that act was based on Eli Bauer's research. Socially maladjusted was considered a conduct disorder, as I said previously. In 1997, the reauthorization dropped the serious emotional behavioral disorders, but it still kept that term. It also added functional behavioral assessments, behavior intervention plans, and manifest determination review as part of the IEP process. In 1990, they reauthorized IDEA again with the goals of providing and maintaining an adequate number of qualified personnel, developing capacity of schools and communities to meet the needs, to secure and expand inclusion of students with disabilities, and identify measures for and improve results for students with disabilities. The next article, Programs for Children with Emotional Behavioral Disorders in the United States, a historical overview, current perspectives, and future directions. So in the 1900s, they had establishment of professional groups, such as the National Committee on Mental Hygiene in 1909, Council for Exceptional Children in 1922, Council for Children with Behavioral Disorders in 1964, and it also had some direct services, the Juvenile Psychopathic Institute, the Clinic for Child Development, Bellevue Psychiatric Hospital, all focused on psychiatric and mental health issues, for students with disabilities. The government also got involved. In the 1930s, they instituted a new office called Children's Bureau. Children and Adolescent Service System program began in 1984. The Mental Retardation Facilities Construction Act in 1963 provided funds to prepare teachers to work with students with disabilities. And in 1975, the Education for All Handicapped Children's Act provided FAPE, or free and appropriate public education, for students with disabilities. Some of the statistics. Students with emotional behavioral disorders represent 8.2% of all students being served in special education. It's about 8,500 students nationwide aged 3 to 5, about 160,000 nationwide aged 6 to 11, 287,000 nationwide aged 12 to 17, and 25,000 aged 18 to 21, which brings us to a total of about 482,000 people nationwide who are serviced under special education law for emotional and behavioral disorders. So some of the outcomes throughout history, and it's still true today, students with emotional behavioral disorders are the most underserved disability category under IDEA. They fail more courses, they earn lower grades, they miss more school, they're held back more often, they have a really high dropout rate of 55%. Only 42% of students with emotional behavioral disorders graduate on time. 58% of these students are arrested within 3 to 5 years of leaving school. So a really high arrest rate. Their outlook post-secondary does not look good. And this research has been very similar for the last 20 or 30 years, unfortunately. Understanding emotional behavioral disorders, are we paying the cost of borderline ethics? So some of the ethical issues with the current definition is that it's very vague and contradictory. So it says that they have to have experienced these symptoms for a long period of time. But how would you define long? If you're a parent of a student who's having issues, a long period of time for them might be a month. But for the school district, it might be 6 months. It's not very specific. To a marked degree. Well, what exactly does that mean, to a marked degree? Are they failing one class? Are they failing two? Are they failing all of their classes? Do they have to get outside counseling now? Are they withdrawn? What exactly does that mean? And it has to adversely affect. So what is adversely affecting? Is that a general, they're failing, they're not participating, they're not engaged? Is it relative to the student and what they were experiencing or performing prior to their being referred for evaluation? It's really vague and it's really ambiguous. The exclusionary maladjustment has prevented many, many students who should have received services from receiving services. As I said earlier, many school districts consider conduct disorder as socially maladjusted. Why they do this, it could be a whole host of numbers. They could see it as social maladjustment. They could see it as a drain on the system, since typically those students with conduct disorders don't really improve over the course of their educational career. But there's no empirical data in any of the research that differentiates emotional impairment from socially maladjusted. And while conduct disorder is an outside diagnosis, oftentimes when students are being evaluated, they do have scales that rule out or rule in conduct disorder. And if it rules in conduct disorder, they're not deemed eligible for special education services. Even though conduct disorder is a DSM criteria and it's very different. Nowhere in the federal or the Michigan definition does it say anything about conduct disorder or conduct disorder being excluded. So it's one of those ethical issues. There's some contradictory research. There's limited empirical evidence of efficacy for strategies. So there are very few studies to begin with that talk about effective strategies for students with emotional behavioral disorders. And part of the reason is that because this is more than other disabilities considered a low incidence disability, you don't have a lot of students who have this. Those that do have some empirical validation, such as positive behavior support, are not used. Many schools, instead of using positive behavior support, FBAs, BIPs, they use expulsions and suspensions instead. And much of the data that we have about students with disabilities in general do not generalize to students with emotional impairments. Discipline for students with emotional impairments is still very harsh, especially when we're talking about zero tolerance offenses. It's also very discriminatory against students with emotional impairments whose primary problem is behavior. So when we talk about a manifest determination review, we're asking whether or not their behavior is part of their disability. And oftentimes it is, because for students with emotional impairments, the primary manifestation of their disability is behavior problems. The next article, Supporting Students with Emotional or Behavioral Disorders, the State of the Field. So in 1991, a group called Peacock Hill did a study about the state of students with emotional and behavioral impairments. They found that 1% of school-age kids were eligible for emotional behavioral impairments under IDEA, but 14 to 20% of kids in general met that criteria, which means that only a third of those who need supports or services were being supported or serviced. 47% of students with emotional impairments have at least one class that they're failing. Less than 50% were actually in gen ed settings. The dropout rate is more than 40%. 40% have a criminal record a few years after leaving, and 1/3 of qualified teachers leave the school setting within a few years. And then they also found that there is very scarce mental health services that are brought into the schools to help these students. Sorry, my dog's snoring. Child count. In 2016-2017, 2,700 children aged 3 to 5 and 335,000 aged 6 to 21 were being serviced under the emotional impairment category. 5% of all students with disabilities is what that constitutes. Both age groups show a slight decline over the past couple of years. Less than 10% of students with disabilities and 1% of all students served with an estimated, less than 10% of students with disabilities and 1% of the students served, with an estimated 14 to 20% of all those students who meet criteria for emotional impairments. The gen ed classroom experience, 47% spend more than 80% in the general ed setting. 17% spend more than 40% of the time. So when you have a student who has emotional behavioral impairments, they are very hard to integrate. Not necessarily because they don't have the skills, either behavior-wise or academic-wise, but it's often because teachers don't want to deal with it and they don't know how to deal with it. Key teaching practices occur at low rates, so attention signals, those nonverbal cues, reviewing prior knowledge, modeling, and the ratio of positive to negative interactions. So remember that ratio should be 5 positive interactions for any 1 negative interaction that you have with the student. Students with emotional impairments have fewer opportunities to respond. They have higher rates of negative feedback. So their positive to negative is 1 to 3.8 instead of 5 to 1. They have lower overall engagement. They receive limited accommodations, and they're more likely to be rejected by teachers. In terms of discipline, they're twice as likely to be suspended out of school. 13 out of every 10,000 kids served under IDEA were removed for zero tolerance offenses, but 50 out of every 10,000 for students with emotional behavioral disorders were removed for zero tolerance offense. 77 out of every 10,000 students were suspended or expelled. This is for all disability categories. There were 365 out of 10,000 students suspended or expelled for those who have emotional behavioral disorders. So that's a huge difference. 37 out of 10,000 students with all disabilities had ISS for 10 days or more, whereas 123 out of 10,000 students for students with emotional behavioral disorders had more than 10 days of in-school suspension. There are also within those disparities, racial disparities. 78% of Black students with EBD received out-of-school suspension, but they only make up 16% of the population. And 56% of Latinos who have emotional behavioral disorders were suspended out of school, but they only make up 25% of the population. 62% of white children with emotional behavioral disorders were suspended, whereas they only make up 50%. So that gap is a little bit less, but it's still a pretty big gap. Some of the outcomes that we've talked about, 73% had unemployed parents. 62% of students with emotional behavioral disorders live in low-income housing. Only 22% have a parent with a 4-year degree. 33% of these students attend low-performing schools. They're suspended at twice the rate and arrested at 3 times the rate as their typical peers. They're less likely to receive accommodations. They're less likely to receive mental health services. So 54% of those who have a label of emotional behavioral disorders don't receive any type of mental health services. That's within the school. So we're talking social work services, psychology services. So the group of students who probably need those mental health services the most are the group that gets it the least. 40% don't graduate and 35% drop out. So there are a few positives. Graduation rates have increased 10% over the last 10 years. Reauthorization solidified some of those procedural safeguards in terms of suspensions. So with manifestation determination reviews, once you're looking at it and you see, yes, this is part of a student's disability, then they're not able to be suspended or expelled because of that particular behavior. Functional behavioral assessments, behavior improvement plans, and positive behavior supports were part of the reauthorization of IDEA. IDEA also really highly recommended that they use evidence-based strategies such as high levels of praise and opportunities to respond, precision requests. So that's something that I often tell all of my teachers. When you're redirecting them, you use as few words as possible, and you don't use any flowery language, or you don't use anything that can be seen as a choice. So instead of being like, hey, don't you think maybe you should start working? Isn't going to work with a student. You have to say, you need to start on number 1. It's very clear, it's very concise, and it's to the point. Direct instruction. So when they're talking about direct instruction, it usually follows the I do, we do, you do. So I model the first problem, and as I'm modeling, I'm talking and I'm going through my thinking process of how I'm working through this problem. And then we do the second problem together, and I use that thinking process to ask questions. So you help me come up with the answer, and then you do, so you do it independently, and then we check your answers. And the direction. So some of the things that are going to be important in the next upcoming years is early identification. As with all disabilities, the earlier that you can get services, the better the outcome. So there is a huge push for universal screening for students with externalizing or internalizing behavior symptoms. Issues with the definition. So this needs to be taken care of. There are a lot of children who are being excluded because this definition is really wishy-washy and it's ambiguous. Unfortunately, a lot of people don't want to alter it because in altering it, it's probably going to include more kids, which means that it's going to cost more to educate them. And as we know, there's always cuts in education. The likelihood of getting more funding because of changing the definition is highly unlikely. They need to come up with a universal tool for screening internalizing behaviors. So remember when we're talking about emotional behavioral disorders, we talk about externalizing and internalizing. So externalizing is often that aggression, that physical property, that non-compliance. Internalizing is depression and anxiety. Those are a little bit harder to notice, especially for teachers who don't have a lot of training in students with disabilities or mental health issues. And the multi-tiered systems of support is also going to be really important. So not just having one level of support, but having multiple layers of support for those students. Our next article, Federal Policy in Improving Outcomes for Students with Emotional Behavioral Disorders, Past, Present, and Future. So this article also gives us some stats. Students with emotional behavioral disorders perform 2 grade levels below peers in reading, math, and writing. They're more likely to be excluded. They're 2 times as likely as students with other disabilities to get suspended. There's a 54% graduation rate and a 35% dropout rate. They're less likely to be included in the general ed setting. 46% spent more than 80% of time in an inclusive setting, whereas it's 62% for all students with disabilities. They're placed in alternative settings more than twice the rate of other disabilities. They're more likely to be arrested, 49% versus 2 to 23% of the other 12 disability categories. And these stats haven't changed since 1991, and that was 1991, that Peacock Hill group. In 1975, we had the Education for All Handicapped Children Act, which provided FAPE, free and appropriate public education for students who have disabilities. And there's a couple of important cases that go with it. The first is Rowley. This was the first FAPE litigation case that resulted in a 2-part test. So when parents felt that their children weren't receiving appropriate services and they went to a due process hearing, there was a 2-part test. And the first one, did schools follow IDEA? So did they follow all of the procedures and the compliance laws in IDEA? And then the second part was the IEP developed for the child to receive educational benefit? So that's part of that individualized part of the individualized education plan. Is that plan, those goals, those services, those accommodations have to be designed so that the child is moving towards the typical progress that their peers make. So that's the Rowley two-part test. Andrew was another case, and they looked at progress in appropriate light of a child's circumstances. So previously, when they're talking about educational benefit, again, it was very vague. What might be educational benefit to some? Hey, they moved from 10% to 20% on their goals, might not be appropriate for others moving a grade level up just like typical peers are supposed to. So in this case, they found that progress has to be individualized as well. So that progress has to be appropriate given the student and their circumstances. So if you have a student, let's say, who has an emotional impairment, who struggles in reading, you might have a student who is very, very bright, and they might be able to jump 3 or 4 reading levels in a year, as opposed to another student who might jump half of a reading level. What's appropriate for one isn't appropriate for all, and that's what the Andrew case said. You have to look at it in light of the child. It also talked about the fact that his IEP did not address his behavioral issues. And they said that not addressing his behavioral issues was part of the reason that FAPE wasn't met for him. And then AH was another case that dealt around behavior. This child had many behavior issues in school, and they had a behavior plan, but it only addressed one issue. The behavior plan wasn't signed, and it wasn't referenced in the IEP. In addition, the behavior plan didn't give teachers any specific strategies or guidelines to follow when the student displayed behavior. So this case also found in favor of the family. So this article also talks about the problems with the definition. They're subjective and they're ambiguous in terms of how you determine what is to a marked degree what adversely affects. This has caused states to have multiple definitions that create a discrepancy. So a child might be eligible for services in Michigan, but if they move to Ohio, they might not be eligible. So the fact that there's this discrepancy means that you have some students who might not get services, they might get different services, and they might get them in different settings depending on the state definition. And then the social maladjustment exclusionary cause also causes a huge problem. Again, as we said, so only 1% of students are being found eligible, whereas 14 to 20% of the general population has enough criteria to meet the definition. They're being underserved, and the exclusionary cause for social maladjustment is one of the biggest reasons for this. So they suggest this definition: a disability that has characterized behavior or emotional responses in school programs so different from age-appropriate cultural or ethnic norms that the responses adversely affect educational performance, including academics, social, vocational, and personal skills. But again, we have some vague terminology. That's so different. What is so different from age appropriate? And again, adversely affects. What exactly is adversely affect? Are you talking about grades? Such a disability is more than a temporary expected response to a stressful event in the environment, is consistently exhibited in 2 different settings, at least one of which is school-related, and is unresponsive to direct intervention in general education, or the child's condition is such that general education interventions would be insufficient. Emotional and behavioral disorders can coexist with other disabilities. The term includes schizophrenic disorder, affective disorder, anxiety disorder, or other sustained disorders, or conduct or adjustment where they adversely affect educational performance. So it's a little bit more specific, but there's still some ambiguous terminology there. MTSS, the multi-tiered system of support, should be used to help early identification of students. That's the best chance we have to have that universal tool. And then integrated system framework, it integrates positive behavior support, the school, and community mental health. So they have to have all 3 of those that are working together to have some good wraparound services to ensure that the student with the emotional behavioral disorder is actually making some progress, not only in school, but also personally and at home. And our last article, the Republication of Toward an Acceptable Definition of Emotional Disturbance. So here's another example of a definition. The emotionally disturbed child is a student who, after receiving supportive educational assistance and counseling services available to all students, still exhibits persistent and consistent, severe to very severe behavioral disabilities which interfere with productive learning. This is a student whose ability to achieve adequate academic progress and or satisfactory interpersonal relationships cannot be attributed primarily to physical, sensory, or intellectual deficits. So again, though, we have some ambiguous terminology. Severe to very severe. What's the difference between severe and very severe? What is considered productive learning? Are you talking about academics? Because a child might not be progressing academically, but they might be learning behaviorally. Is that productive or not? So they view it in terms of these operational attempts. So measurable alternate placements, they have different interventions that have been tried, including changing the schedule, outside counseling, teacher modification, and those haven't worked. The deviation of the behavior persists over a set period of time. It's consistent if you have more than one. It's severe if you have it more than twice a day. It's very severe if you have it once or twice an hour. And it objectively states the behavior. So they had physical or verbal aggression, social withdrawal. So when they're talking about objectively, instead of saying, oh, he had an outburst, well, what exactly does that mean? As opposed to, he went up and flipped a desk and then left the room and left the building. Measurable behavioral interference. There's academic criteria, one standard deviation below, and then they do talk about interpersonal problems, and they only give one example. They give fighting as one specific example. And exclusive etiology, so it's not caused by sensory, physical, or intellectual disabilities. Okay, so let's switch gears and let's talk about the brain. So we're just going to review some of the key structures and functions of the brain. So the first part we're going to talk about is the hindbrain. And the hindbrain is the oldest part of the brain. The medulla is responsible for some of your vital reflexes that you can't control, like breathing, heart rate, vomiting, salivation, coughing, sneezing. The pons is where the axons from each half of the body cross the spinal cord so that each hemisphere controls the opposite side of the body. So remember, your left hemisphere controls the right side of your body, and your right hemisphere controls your left side of the body. The pons is responsible for sending signals to the spinal cord to inhibit movement during sleep. So when we're dreaming, we don't want to actually have control of our muscles because we would act it out and people would get hurt. The locus coeruleus is inactive most times, but it's active during times of emotional arousal, and it releases norepinephrine. So norepinephrine is a form of adrenaline. Any event that activates this area strengthens the memories. So what this basically means is anytime you are emotionally aroused, which is often for students who have emotional behavioral disorders, they get these neurotransmitters released and it makes this memory more salient. So if they remember a time in school where they got called out by the teacher and they now have this emotional arousal response to it, it means that it's more salient. They're going to remember it more. So the next time a teacher maybe is saying similar words or has a similar look or a similar body posture, they're going to remember that time and they're probably going to get emotionally aroused again. The reticular formation is responsible for arousal. So remember, when we're talking about arousal, we're talking about your level of attention. The RAF system sends out signals to ready the brain for responding to stimuli. So this is going to be important when we're trying to attend to different things. The cerebellum is considered the little brain. It's responsible for balance and coordination, aim and timing. It's responsible for recognizing sensory stimuli that's felt, so your touch sense. It also has a role in sustaining and shifting attention. So as we know, students with emotional and behavioral disorders often have difficulty shifting their attention once they get caught on something that they considered a slight or something that was unjust. They have difficulty getting over it. So the ability to shift their attention to something, and not necessarily something different, but in terms of when we're talking to a student, that ability to rationalize and pay attention to you and what you're trying to tell them is difficult. And the lateral interpossus nucleus is essential for learning. The midbrain is the next part of the brain. The supracolliculus is responsible for your vision processing. The inferior is responsible for your hearing processing, and your substantia nigra facilitates your readiness for movement. So these again all have something to do with your level of attention and your arousal. The forebrain is the most modern part of the brain. It's the most prominent part of your brain. It is what holds the two hemispheres that control the opposite sides of the body. And there's a couple of important structures. The first is the basal ganglia. It's responsible for initiating movement. It's responsible for learning new habits. It plays a role in movement, memory, reasoning, and attention. So I have a student, and while he doesn't have an emotional or behavioral disorder, he actually is on the spectrum. When he has a problem in school, it's very clear to see that moment when he has lost all rationality and he's not going to listen to a word that I say, and that moment when he gains it back and he's able to process what I'm saying. And the basal ganglia plays a role in this because it's responsible for your reasoning and your attention. The nucleus accumbens releases dopamine when it's activated by a stimulating event. And stimulating event could be sex, gambling, video games. And it's related to how much you want something, not how much you enjoy it. So when we're talking about these things, sex, gambling, video games, all things that you can become addicted to, it's not necessarily that you enjoy them, but you have that need to actually participate in them. And the nucleus accumbens is responsible for that. This also plays a large role because drugs increase the release of dopamine. So it kind of mirrors that effect. And as we know, you have cravings when you're addicted to drugs, and it's not necessarily how much you enjoy it, but it's how much you want it or how much you need it. The hippocampus is responsible for storage and retrieval of memories, specifically declarative memories, which is facts, spatial memory, so the ability to remember like how you get home from school, and context. So context is going to be important because when we think about memories and we think about what happens, the context of our memories is going to be important. So if you have a student who got into some type of trouble, they're going to have to remember that, oh, well, I did this behavior, and in this instance it's acceptable, but in this instance it's not. And let me give you an example of that. So I have many students on my caseload who have emotional behavioral disorders. Obviously, them pushing a desk over and swearing in class isn't appropriate. But if they come into my office where there's nobody in there, then they can swear and they can knock over a desk if they want. Because they're out of everybody's view, there's nobody who can be harmed, and it's in an appropriate setting. And what happens is that many times they have to have that release before they start to gain that rationality back, and we can work through the situation. So if they have that small release, if they knock over a desk and then they're like, okay, now I can talk to you about this, it's better that it happens in that appropriate environment where then we can work through and we can debrief after it, as opposed to having it in the school, in the classroom. So context and that learning of when I can do this and when I can't do this is going to be important. The hypothalamus plays a role in motivated behaviors such as feeding, drinking, sex. It's also responsible for temperature regulation. It's also responsible for fighting behaviors. The thalamus is our relay center for sensory input, all of our senses except for smell. It's responsible for focusing our attention on stimuli. The amygdala is going to play a key role in the research that we talked about. And the amygdala is the emotional regulation center, specifically fear and aggression. It links to the prefrontal cortex that controls approach and avoidance behaviors. So approach and avoidance behaviors are going to be huge, as we know that's something that we look for in the functional behavioral assessment. The amygdala is active in fear conditioning, and people who have damage process ambiguous details as emotional. So it could be somebody's tone of voice or the way that they're sitting or the pitch of their voice. And they might see what typical people see as neutral stimuli. They might take it as emotional or threatening. And the cingulate gyrus regulates pain and emotion. It also is responsible for predicting and avoiding negative consequences. So that's going to be key for students with emotional behavioral disorders. They do not have the ability to predict and avoid their consequences. They can't control their behavior, so they do whatever comes to mind and whatever they feel. And they can't think, oh, I should stop and not do this. And our cerebral cortex is our executive functioning center. That's our frontal lobe. It's responsible for thinking, planning, decision-making, personality. It is what makes us, us. This is going to be key for students with emotional behavioral disorders because they don't have the ability to do a lot of those things, to make good decisions, to plan. They just are not capable of it because of their disability. So let's talk specifically about the cerebral cortex. The occipital lobe is responsible for vision. Our parietal lobe is responsible for sensation, touch, and body location. Our temporal lobe is responsible for hearing. It also plays a role in emotions and motivation. And damage to our temporal lobe leads to loss of fear behavior. So that thrill-seeking behavior would increase if we have damage to our temporal lobe. And our frontal lobe is our executive functioning center. It's also responsible for working memory, so our short-term memory. Our hemispheres, so that theory that we're either right-brained or left-brained isn't really true. That's kind of a fallacy. We might have one that's a little bit stronger, but we don't have one necessarily that's dominant. So some of the things that our left hemisphere is responsible for, language is one of them. That's the big one. It's also responsible for math problem solving, analysis or analytical thought, rational thought, verbal thought. So all those things that deal with language and being analytical and analysis. Our right side, however, deals with perceiving emotions, recognizing faces, understanding metaphors and humor, figurative language, math reasoning. Okay, so let's talk neurotransmitters because that is going to be important as well. So acetylcholine controls our muscle contractions. An excess causes muscle spasms, and a deficit causes paralysis and death because we can't breathe. Dopamine is going to be important. Dopamine is our pleasure center. It's also responsible for voluntary movement, learning, and memory. Drugs increase dopamine, which is why they're so pleasurable because our dopamine is our pleasure or our reward center. Too much dopamine causes hallucinations, thought and emotional disturbance. So dopamine is linked to schizophrenia. Dopamine does play a key role in our addiction and reward system. So a lot of the research in chapter 2 is going to talk about our dopamine systems. Endorphins are naturally produced opioids. They're inhibitory, which means they stop the effect. So they block pain and they block pain messages. It increases our self-control. It boosts our immune system. It also gives us a pleasurable feeling. That's that runner's high. It plays a role in mood, memory, learning, and sexual activity. Epinephrine is responsible for emotional arousal and memory storage. So emotional arousal, again, is going to be key in those kids with emotional behavioral disorders. GABA is inhibitory, and it is what regulates our anxiety. So when we're talking about anxiety disorders, GABA is going to be the key neurotransmitter. It helps calm our anxiety. So any type of anti-anxiety drug like Paxil works on the GABA receptors. Tranquilizers and alcohol bind GABA and have a calming effect. That's why people have a drink to take the edge off. Deficits are linked to depression and schizophrenia and anxiety. Glutamate is excitatory. It's responsible for learning, movement, memory. It also plays a factor in depression and anxiety. Underactivity is linked to schizophrenia. Norepinephrine speeds up our heartbeat and our other body processes. This is what's linked to that fight or flight response. Excesses are linked to, and deficits are linked to mood disorders, excesses specifically to manic states. And we didn't talk a whole lot about bipolar in terms of the eligibility criteria, but many students who have bipolar disorder are found eligible under emotional impairment as opposed to other health impairments. And serotonin is responsible for emotional arousal, sleep, appetite, aggression, and mood. And deficits in serotonin do lead to depression. Low turnover, so the amount of neurotransmitter that's actually replaced and released, is linked to aggressive behavior. Monkeys with low turnover were the most aggressive, and they had the largest probability of trying to attack other larger monkeys. They had the most injuries, and they were more likely to die young. In humans who have low serotonin turnover, it's linked to violent behavior, more violent suicide attempts, greater recidivism rate, so they're more likely to commit the same crime more than once. The brain releases serotonin during aggressive behavior, and that gets magnified at the start of an aggressive episode. So it's kind of like the cycle where you're kind of primed for this aggressive behavior because of your serotonin, and then once you experience this aggressive behavior, it releases more serotonin. And our last slide, brain development and disruptive behavior. So the maturity trajectory, 95% of our brain is developed by age 6. Emotional and behavioral regulation, as well as motor control, increases as our brains develop our myelination and synaptic pruning. And with age, the developmental pattern of diffuse activation and inefficient brain interconnectivity moves. So you're no longer having these poor connections between your neurons, and you're no longer clumsy in your motor movements, but now you have efficient, strong connections between your neurons, and you're able to move effectively. So some of the brain structures, there is a correlation between aggressive behaviors and smaller volumes of the right anterior cingulate cortex, the anterior cingulate cortex, and the amygdala. And MAOA is an enzyme, and it's a polymorphism that relates to aggression. And the prefrontal cortex, as we said, does not develop fully until you're age 25, and that is responsible for many of the executive functioning that we have, so planning, decision making, making those good decisions, the ability to control your behavior. So our next slide is just the references. So these all can be found on your Canvas site as they are assigned readings, and I look forward to seeing you guys next time.